the median nerve, anatomy, pathways, and clinical insights. Welcome back to the Everything Surgery podcast, where today we are diving into a detailed discussion of the median nerve, its anatomical course, relationships, and distribution, along with key clinical correlations. Join us as we dissect the extraordinary role of this principal nerve in upper limb function. Overview of the median nerve. The median nerve is a mixed motor and sensory nerve, originating from contributions of the lateral and medial cords of the brachial plexus, specifically from roots C5 to T1. This nerve stands as the principal nerve supplying the anterior compartment of the forearm and the opposition aspect of the hand. A defining feature of the median nerve is its passage through the carpal tunnel to enter the hand, and notably, it does not give off any branches within the arm itself. Course and anatomical relations. Let us trace the journey of the median nerve from its origin to its terminal branches. Formation and course. In the arm, the median nerve is formed by the union of a lateral root, derived from the lateral cord, C5 to C7, and a medial root, from the medial cord, C8 to T1. This union occurs anterior to the third part of the axillary artery. As it descends within the arm, the nerve initially lies lateral to the brachial artery. In the midarm, it crosses to lie anterior, usually superficial to this artery, before finally positioning itself medial to the artery in the region known as the cubital fossa. Throughout its course in the arm, the median nerve remains in the anterior compartment, deep to the bicipital aponeurosis, and does not issue any branches. Relations in the cubital fossa and forearm. Within the cubital fossa, the median nerve is situated medial to the brachial artery and lies deep to the bicipital aponeurosis. It proceeds between the two heads of the pronator teres muscle to enter the forearm. In the forearm, the nerve travels along the midline, closely adherent to the deep surface of the flexor digitorum superficialis muscle, and is positioned atop the flexor digitorum profundus muscle. In the distal forearm, it becomes more superficial, emerging between the tendons of the flexor digitorum superficialis and flexor carpi radialis, just lateral to the tendon of the palmaris longus, a useful landmark in surface anatomy. Course at the wrist and hand. The carpal tunnel at the wrist. The median nerve passes deep to the flexor retinaculum within the carpal tunnel. Here, it is the most anterior structure, lying superficial to the flexor tendons. The carpal tunnel itself is a rigid fibroosseous canal formed by the carpal bones as its floor and the flexor retinaculum as its roof. Within this confined space, the median nerve travels alongside 9 tendons, 4 each from the flexor digitorum superficialis and flexor digitorum profundus muscles, and 1 from the flexor pollicis longus muscle. Immediately distal to the flexor retinaculum, the nerve divides into its recurrent motor branch and the cutaneous palmar digital branches. Branches and distribution. Branches in the forearm. In the forearm, the median nerve gives off muscular branches that supply the pronator muscles, including a branch to the pronator teres, often given off proximal to the elbow. One of its major motor branches is the anterior interosseous nerve, which arises just distal to the elbow and descends upon the interosseous membrane between the flexor digitorum profundus and flexor pollicis longus muscles. The anterior interosseous nerve supplies the flexor pollicis longus, the lateral half of the flexor digitorum profundus, serving the index and middle fingers, and the pronator quadratus muscle. Although it does not carry cutaneous sensory fibers, it provides proprioceptive and articular branches to the wrist. Additional muscular branches from the median nerve supply the flexor carpi radialis, palmaris longus, and the flexor digitorum superficialis muscles. Notably, the palmar cutaneous branch arises proximal to the flexor retinaculum and pierces the deep fascia to supply the skin over the lateral aspect of the palm, specifically the thenar eminence. Terminal branches in the hand. After passing through the carpal tunnel, the median nerve divides into its recurrent motor branch and the palmar digital nerves. The recurrent motor branch, which shows considerable anatomical variation, typically hooks proximally and laterally to enter and innervate the thenar muscles. It may pass over, through, or under the flexor retinaculum. The motor distribution includes the 3 thenar muscles responsible for thumb opposition, the abductor pollicis brevis, opponens pollicis, and the superficial head of the flexor pollicis brevis. The palmar digital nerves are responsible for both sensory and motor functions. They provide sensation to the palmar skin of the lateral 3½ digits, the thumb, index, middle, and lateral half of the ring finger, as well as the dorsal skin of the distal phalanges of these digits, including the nail beds. Motor supply is directed to the first and second lumbrical muscles. which are essential for fine movements of the index and middle fingers. The loaf mnemonic and clinical correlation to remember the intrinsic hand muscles supplied by the median nerve. Use the loaf mnemonic. L. First and second lumbricals. O. Opponens pollicis. A. Abductor pollicis brevis. F. Flexor pollicis brevis. Superficial head. Loss of median nerve function in the hand leads to distinctive signs. Motor impairment can present as the ape-hand deformity, characterized by a flattened thenar eminence and the thumb being pulled into adduction and extension due to the unopposed action of muscles supplied by the ulnar and radial nerves. Sensory loss affects the lateral palm and the palmar surfaces of the lateral 3½ digits, compromising fine precision grip and tactile discrimination. Major clinical syndromes. Several syndromes are associated with median nerve dysfunction. Pronator syndrome. This arises from compression of the nerve in the proximal forearm, often between the heads of the pronator teres, beneath the arch of the flexor digitorum superficialis, or by a thickened bicipital aponeurosis. Patients experience forearm pain and weakness. Anterior interosseous nerve syndrome. This is a pure motor palsy. Patients cannot form an OK sign because of paralysis of the flexor pollicis longus and the lateral flexor digitorum profundus, resulting in a pinch deformity with the thumb interphalangeal joint and the index distal interphalangeal joint remaining extended. Carpal tunnel syndrome. The most common entrapment neuropathy. This syndrome involves compression of the median nerve within the carpal tunnel. Importantly, the palmar cutaneous branch is spared as it arises proximal to the tunnel. Symptoms include pain, tingling, and numbness in the lateral 3½ digits. Nocturnal symptoms, and thenar muscle atrophy in advanced cases. Conclusion. The pathway of the median nerve highlights its essential role in pronation, wrist and finger flexion, especially in precision pinch, thumb opposition, and providing sensation crucial for fine tactile discrimination. Its unique anatomy and distribution underscore its importance in clinical practice and surgical procedures. Thank you for joining us for this exploration of the median nerve. If you appreciate our in-depth content, be sure to like, share, and subscribe. Stay tuned for more episodes from the Everything Surgery podcast, where we continue to dissect the extraordinary.